Is there any chance to see the slides from here? Okay, so perhaps I will go to... yeah, but this is just on this small monitor here. Okay, thank you very much, Oscar and Marcia, for the invitation. I think that you gave me the difficult topic, how to interest everyone who knows everything about the DVT with this kind of pathologies, but I think that we can have different approaches, and also there is a lot of data which can be included. Of course, the prevalence is quite high, and you all are familiar with this. Not all the cases are as symptomatic as this one on the screen. From the European data, which is the extrapolation of the 6 big countries epidemiology evaluation, we can have up to 500,000 of VT-related deaths per year, and this what is also important, because we don't talk about this so much, 600,000 PTS patients in Europe a year potentially. So it's a big number of patients which are our potential candidates. And of course, the number of almost 500,000 of PE events in Europe, it's very, very suggestive. If you look into the US data, 100,000 people dying because of VT every year in United States. There are huge differences regarding the prevalence of the VTE, which were for me very surprised. For example, in Hong Kong, the annual VTE incidence is 79 cases per 100,000 per year. In Denmark, you have 4 times more. If you look into the DVT annual incidence between the Korea, these countries, and Sweden, it's 3 times more. And of course, the age relation is something which we all are familiar with. If you compare heart ischemic disease, stroke, and atrial fibrillation and venous thromboembolism, we see that we have almost the same number of stroke patients in the population as VTE patients. However, the VTE remains the 3rd reason for death in the current Westward population. This is the schema which shows us who are the patients which we are dealing with. So 40% of all VTE patients will manifest pulmonary embolism, 60% DVT, and among them 10 to 15% are the patients with iliofemoral DVT. So it seems that we deal with a quite big number of patients which can be potential candidate for the treatments which we discussed today. Of course, in this group there are patients which are very symptomatic and very severe, like Marcia mentioned about the patient with highly symptomatic iliofemoral DVT. But the same is about the P patients. It's not wonder right now that we focus on the organization of the paired teams in our hospital, because the groups of the patients which we can potentially treat and help successfully in a severe hemodynamic condition is still a big one, and it's the space for the further development. Of course, we can deal also with asymptomatic patients. We should remember that 80% of the distal DVT is without symptoms, and up to 50% of the proximal DVT can also not manifest enough clinical symptoms to be diagnosed. And in many of the patients, we still have the PE as the first moment when we can try to diagnose the patient properly. And this is much more commonly in the patients with medical history. So patient not treated surgically, it's still the place where there is a lot to do regarding the awareness in terms of the proper prophylaxis. This is the wonderful schema from Ari Merkel study showing what happens to DVT years after. And from this schema, we see that 2 years after the disease onset, just 20 to 30% of the patients will have the normal veins. 20% of these veins will remain occluded completely for the rest of the life. And in majority of patients, 40 to 60% will have post-thrombotic changes which will influence on the patient clinical course and also post-thrombotic syndrome occurrence. We know that residual vein obstruction, this is what happens to 40–60%. It's something which is increasing the rate of the DVT recurrence. We know this, for example, from DACUS study. And we know that residual changes it's a much higher risk of post-thrombotic syndrome. It's one of the predictive risk factor for PTS occurrence. Of course, what's post-thrombotic syndrome, everyone is familiar with this term. Its definition coming from vein term consensus, and we know that these two components, valve damage and vein obstruction, matters. The combination, we are not sure about this because in some of the series there were just reflux patients, but it seems that combination of these two components increase the risk of post-thrombotic syndrome. And we deal with the 20 to 50% even of the patients after DVT episodes. This what is important is a very poor correlation between the clinical symptoms and this what we find in phlebography. I think that everyone of you saw the patient with completely occluded iliac vein without special clinical symptoms, which does not require any treatment. What is important, one more component which we start to talk again, it's inflammation in terms of secondary chronic disease. We know that this can be inflammation in the vein and in the vein surrounding, and also inflammation related to the secondary chronic venous disease, as we know from pathology of this clinical abnormalities. And we have the studies that the higher inflammatory parameters are the predictive factor. We do not have the good biomarker, but from several studies we know that if CRP is high or if interleukin-6 is higher, there is the higher probability of post-thrombotic syndrome development. But this, of course, needs the further research to identify the proper biomarkers of PTS development. However, secondary chronic venous disease happens, and it's not always the primary disease. It's not always related to symptomatic disease. Sometimes it happens some years after asymptomatic disease. And here from the orthopedic studies based on phlebography or ultrasound confirmation of the DVT presence is the prevalence of post-thrombotic syndrome in asymptomatic DVT patients from the prospective observational or randomized control studies. As you can see, the number of patients, the rate of patients is very, very significant. So asymptomatic patients can be really sick in the near future. Of course, DVT location matters. We know that there is more PTS cases from the group of the patient with massive proximal DVT. But if we look to these studies, for example, like the Cactus PTS study, we can count on 1/3 of the population of the distal DVT patients to become the patient with post-thrombotic syndrome in the future, including 1/4 of them having the severe disease. So distal DVT in terms of this matters. So not only post-thrombotic syndrome as the sequels of this disease, venous thromboembolism, we can talk about the chronic thrombotic pulmonary hypertension, but this is probably not the task of today's conference. I just wanted to mention something which we started to talk already 5 years ago. It's called post-pulmonary embolism syndrome. So it's not only hypertension, but this is something like we have right now in this post-COVID era. We speak about long COVID. So right now we have the term which defined as a progressive dyspnea, exercise intolerance, and impaired functional or mental status after at least 3 months after PE. And we start to know more and more about this. This is something which potentially influence the patient's quality of life. You don't need to have pulmonary artery hypertension to be defined as the patient with that kind of pathology. However, it starts to be discussed as a potential factor which influence on the patient quality of life in terms of the sequels of venous thromboembolism, in this case PE. Several risk factors are known. I wanted just to mention that transient risk factor is like up to 30% of the population. The rest of the patient will have the continuous permanent risk factor, or we have idiopathic DVT. Of course, one of the important factors is cancer, which we will not discuss here, but just to mention that there is a quite big group of patients which should be included in terms of the concomitant or previous disease occurrence. Virchow's triads we are all familiar with. We look for this, for example, in surgical patients, but we should be aware that the same Virchow's triad can be identified in the medical patients, and it's quite common nowadays in the patients with so many comorbidities which we treat in our hospital. And the last what I wanted to touch is ascending and descending DVT. Both of them can be the patients which are potential candidate for our invasive treatment of DVT, which we would like to discuss today. But iliac vein compression, it's something which we should much wider than just May-Turner syndrome only. Of course, the history of May-Turner is over 100 years when the researchers started to talk about this and was defined in 56. Today we know that this can be compression on the left side, can be compression on the right side, can be multifocal compression, and not only compression but also several intraluminal changes can be present. So it's not wonder that we should look not directly the place of the crossing iliac artery, but also in other locations where this can happen. And clinically recognized May-Turner syndrome, it's at least 2 to 5% of all DVT cases. So we speak about the big group of patients, and MTS is present in 18 to 49 of the patient with proximal left lower extremity DVT. So we should look for this pathology not only in Neville patients, like these patients, but if you do any case of the acute DVT, like this one with penumbra thrombectomy, you should be always prepared to correct this, what is the underlying lesion. If you have the proper vein opening, the upper part should be for sure stented. And also for the chronic cases, if we deal with this kind of pathology, we should be prepared to correct everything which is stenotic. That's why IVUS, that's why all this what we talk about yesterday. And I think today will be a lot of discussion about the venous stenting in the proper location to ensure the proper inflow and outflow. And this is my last slide, the costs. There are the costs from 10 years ago, 2011, 2012. Currently, if we add to this cost the cost of the new devices, stuff like thrombectomy, thrombolysis, and all this what we use, and also the cost of the current updated medical service, we deal with a huge number of money which we spend on this disease, so we should for sure try to do our best to perfect in this. And this is my last slide. For those of you who have the time in the end of June, I wanted to invite you to Krakow to European Venous Forum. There will be a lot of discussion about deep veins as well. Thank you very much.
Thank you very much. Special thanks to Marcia and Oscar, to